Welcome to Emergency Preparedness during the COVID-19 pandemic. My name is Eric Gorelnik. I am an associate professor of emergency medicine at Brigham and Women's Hospital at Harvard Medical School and the medical director of emergency preparedness and our Access Center. I have no financial disclosures or conflicts of interest regarding the material presented. I've spent the last 15 years in the world of disaster medicine. And when we talk about pandemics and talk about emergency preparedness, people in many regards think that you're crazy. And then when you actually have a pandemic, people suggest that you weren't crazy enough. So our goal today really is to talk about what is emergency preparedness and outline 5 key principles to help us lead through our pandemic. Define the mission, organize your team, make planning assumptions, lead by objective, and using Colin Powell's 40-70 rule. What is emergency preparedness? Emergency preparedness really stems from emergency management, and emergency management is focused on 4 cycles: prevention and mitigation, preparedness, response, and recovery. And when we think about emergency management, it really is a core function throughout our healthcare system and well beyond. It really began in the public safety sector with fire, police, law enforcement, emergency medical services, and public health, and then spanned into the healthcare system, recognizing that we need to navigate disasters or crises. And these disasters could be ones that result from human factors like terrorist bombings, like the Boston Marathon bombing of 2013, or an active shooter. This can also be a result of technological failures. For example, when you have an information systems downtime due to a power outage, or it could be due to natural hazards. And that could be any form of all-weather event. For example, hurricanes, blizzards, floods. And our role and responsibility within our healthcare system is to help prepare for these events, working with multiple stakeholders to help define roles and responsibilities prior to the event, and a clear process to prepare, to respond to these events. So in the moment, during the event, to help facilitate the individuals in the room to help organize a response. And of course, the long tail, which is the recovery. And in many regards, people focus on the preparation and really the response. But the tail, the recovery, is really the critical piece here that gets little attention, but is the long tail of these events. And we say in Boston that although April 15, 2013 was the Boston Marathon bombing, our marathon began the moment after those bombs went off, thinking through the long recovery for all of our patients, family, and staff from that event. And of course, mitigation, thinking ahead about all of these various hazards and how we need to prepare and potentially mitigate some of these effects. So for example, thinking through if there's flooding or you're on a flood table within your healthcare system, should you consider moving critical resources from the basement or below ground to the roofs, for example, generators and other types of resources, and that's one way to mitigate potential impacts. And the focus of all of this is to maintain current operations. Right? We want to ensure that throughout any type of hazard, any type of event, that we are open and welcoming to patients, families, and staff, and that it's critically safe during these events. So with this, we obviously are in the midst of one of the largest scale disasters in this world's history, an unprecedented pandemic regarding COVID-19. And I thought we could spend our time talking about some key principles that we can leverage from emergency preparedness for either your activities during this pandemic or in some regard, day-to-day activities. So principle number one is clearly define your mission. When we look back in January, this is in January, we saw that essentially in the United States, there were very few cases. There were 15 positive cases, 392 cases that were negative. Several cases were pending for a total of less than 500 potential cases. What we know now is that far underestimated the potential patient load, but there was a lot of churn, if you remember, right at the beginning as we started to creep up there was a lot of anxiety, a lot of concern, and a lack of clarity on what direction we were going to go into. And then what happened here in Boston is there was an event. Biogen, a pharmaceutical company, had an event here in Boston, and that became essentially a super spreader event that began to tip cases in rapid fashion. So we received a call from the Massachusetts Department of Public Health epidemiology team, we being at Brigham and Women's Hospital and Mass General, and they said, look, we've had this event, we've had a couple of positive cases, and we need your help to set up rapid testing with your organization and with several hundred employees at both sites. So while all of this churn was occurring and we had already staffed up a response, we were getting the reports from China, globally, from Seattle and other places, as I just stated. This event helped us focus. And we became very clearly focused in the minute to say we have to have, within 24 hours, a testing site ready to go. And so we gathered and formed our hospital incident command system and clarified roles and responsibilities. And we built out a drive-through COVID testing center within a matter of hours. And we were able to handle a significant capacity, several hundred that came over the course of the week from Biogen, and began to scale our testing rapidly. And this is something that we had not done before. This is a picture of our ambulance bay where we set up these barriers. We set up with personal protective equipment and clinicians, car side very rapidly to be able to perform testing in a safe, appropriate manner. And just a week prior, we had essentially done our first test. So when we talk about mission clarity, the focus here is really to focus your team from the outset on what the mission is. In this case, we were able to focus all of our attention on this response with regard to the Biogen event and rapidly form and focus our team to respond and prepare a novel innovation, a focus on a drive-through testing capacity in short time. And then shortly thereafter, we had a large retreat. And our retreat, we started it out by saying, this is our focus. Brigham Health will be able to provide appropriate care to COVID-19 patients while maintaining other essential medical services in the community during and after a pandemic. It's critical from the outset to focus your team on a mission, to say just as important what we are going to do as what we are not going to do. And we wanted to ensure that we provided care for both COVID and non-COVID patients throughout this pandemic. Because remember, some suggested a tunnel vision really focused on COVID alone, and that could have a significant impact on many other patients who really need care in an emergent setting. Number two is organize your team. This concept of organizing your team with regard to emergency preparedness goes back to the early 1970s. And I want to talk about this concept of incident command system. Many of you probably operationalized a hospital incident command system, but it's important to understand the history and how this idea evolved. So in the early 1970s, there were several wildfires in California, Northern California, that went over several state lines. There were many different firefighting agencies that responded to that event, other public safety professionals. And during the event, the challenge was not only the fire itself, but really the coordination between these different fire services. There was no common language between these different groups. They used different types of codes and communications. They use different radio channels. They use different types of equipment. They use different types of procedures to fight fires. And so when you had different fire services responding to the same scene using different protocols, different modes of communication, that obviously combined for confusion, exacerbated the event itself, and caused some significant issues as they were responding to this complex dynamic event. So shortly thereafter, a group came together and called FireScope. And this group, involving some consultants from RAND and the aerospace industry, they came together and did an after action review of the event itself. Now, an after action review was really built on this concept from the US Army, where after an event, there is a rapid hot wash or debriefing to understand what went well and where we can improve. This was a structured after action review, and what they highlighted were many of the concepts and ideas that I just pointed out. And that brought us to the need to design a system that is standardized, scalable, so that there would be a defined organizational structure between different organizations that would be responding in public safety. For example, if there was fire and law enforcement, and on top of that, public health or emergency medical services, how do they combine and work with each other and integrate, have role clarity, so who does what during the event, have a consistent nomenclature across each one of these different groups, so that when having a conversation, you can relay very clearly what and how we would interrelate and what our specific mission is and the overall mission. Unity of command. So again, instead of working in various silos, or as we like to say at Brigham and Women's Hospital, cylinders of excellence, different silos, instead of different silos working together with one focus, and the ability to expand and contract based on the disaster and the responding teams, in addition to a reasonable span of control. Span of control is the concept that really, if you have any more than 6 to 8 direct reports, that span of control becomes challenging, right? It's very hard to be able to focus a team if it gets broader and broader, to both be able to receive information and push out information. So a reasonable span of control we suggest is 6 to 8 personnel. And on the right, the diagram reflects what that structure would look like. And these concepts are essentially having an incident commander who is overall responsible for the event and the event's response. And the incident commander is defined as a person that is on scene. It's critical that the individual is on scene and present during the event. And they are the most qualified to assume responsibility for the event. So for example, we have a flood in our hospital in the middle of the night. The most senior administrative personnel are our nursing administrators. And they are the most senior qualified personnel on site, and they would assume the role of an incident commander during the initial response. And then once they activate our emergency operations plan and inform more senior level individuals like vice presidents and other leaders across the enterprise, once one of those individuals comes in to assist, they may assume the role of incident commander because they may be more qualified to work as the lead for this response. The direct reports to the incident commander are 4 section chiefs. Each section is operations, planning, logistics, and finance. Operations are the individuals, they're the doers. They're the ones that are assigned a role and responsibility and execute on those immediate needs. And the planning section, they actually are the strategy personnel. So they are the ones, they're the thinkers. They're the individuals that set the incident objectives, and we'll speak more about that shortly. Once they set the incident objectives, then operations executes on those objectives. So typically, then you have logistics, which essentially is all the supply chain and support infrastructure. And then of course, finance. We need rapid access to funding during these disasters in a very structured way, and timely procurement of various resources so that both the planning section can consider things like personal protective equipment constraints and how that would apply to the operations team to execute. Those are the 4 main sections. And then you have a command and general staff, which consists of your safety officer, your information officer, and your liaison. Safety officer independently works and is present on site for these various events to ensure there's safety maintained through whatever tactics are used during the response. Information officer is your public information officer. That's your communications officer, public affairs officer, which is a critical function during these events to have clear, transparent, timely communications during these events. And liaison is a liaison typically to other entities, whether they're government or non-government organizations. So for example, here in Boston, we have both our non-governmental organizations like the Conference of Boston Teaching Hospitals, the Massachusetts hospital association, of course, government organizations like the Department of Public Health, Health and Human Services, and the Boston Public Health Commission. So the liaison is the link for your staff and your team and the incident command structure to link with other organizations. And so this, again, this roadmap of the incident command system was born in the early 1970s, and it began to add structure, and more states began to adopt this on the West Coast. And then in 1982, there was an air crash in the Potomac River. And during this event, there were over 70 individuals. Only 4 or 5 of them were actually survivors from this event. And you can imagine this was a crash in the icy waters, and there were several states that were responding to this event. There were individuals from Maryland, individuals from the District of Columbia and Virginia, all responding. And again, it was chaotic, caused confusion. And from this event, they eventually adapted the incident command system on the East Coast. In the late 1980s, this then transmitted into the hospital incident command system, which has a very similar structure. You could see the various section chiefs, and there's a few additions there. It includes medical technical specialists. So medical technical specialist in this case, during a pandemic, can be an infection control or infectious disease expert, could be emergency preparedness expertise. Regardless of the type of event, you would want someone that can speak to the specifics from a medical perspective or any technical perspective. For example, if it's an information systems downtime, when Boston Children several years ago had a cyber attack here that set off their computers and their information systems for several days. So you could have a chief medical information officer or a CIO functioning in that medical technical specialist to provide direct information to inform the team across the board, so they can have timely information and execute on that information on critical decisions. And then, of course, in this scenario where you have operations, you have various clinical units that assume those roles of operations. This has a clear linkage with public safety, as we said, between law enforcement, fire services, and others. And then in 2004, the National Incident Management System, NIMS, took place, so that became a standard. After 9/11 and the Department of Homeland Security was stood up, this became a standard in the industry. This is now a Joint Commission and CMS requirement to maintain a HICS system and all the response systems in place. In addition to, in 2014, when there was a HICS revision, which outlined some more roles that were added to the HICS team. So clearly organizing your team, in our case, thinking going from a matrixed organization where we have various clinical departments, we have various other non-clinical departments, and how we work together on a day-to-day basis. When we have a focused mission and a crisis, we need to think through those key principles of aligning on one mission, a unified command, and having role clarity and a clear reporting structure to both acquire information and listen and execute on that information that in many times is limited, but we do the best we can with the information available. We've used HICS in a variety of different cases over the years in complex crises, from the Boston Marathon to the Ebola pandemic or epidemic in 2014-15, to Snowmageddon in 2015, to when we went live with Epic and thinking about that significant change in May of that year, where we went from one electronic medical record to Epic across our healthcare system, and an active shooter that we had in 2015. In each case, people have, our team has familiarized ourselves with the terms, the roles, the responsibilities, and we continue to have refresher training on an annual basis, but we have many more events where we learn to work with each other focused on one mission. This is essentially what our organization looked like through the pandemic response. I just want to highlight some of these key roles and responsibilities. We mentioned medical advisors, in this case, infection control and emergency preparedness. The remainder of our team here with each of our section chiefs, and highlighting here also medical staff advisor. In our case, our chief medical officer served in that role and was a direct linkage with our existing chair. So we married our day-to-day activities and organization with the hospital incident command system. So we had clear roles, responsibilities, authority, and execution. And that's a critical function also, which is empowering our frontline, empowering the individuals that are closest to the patient to make the best decisions they can with the information available, and being able to push that information up the chain of command, and then being able to listen and then push-pull information both up and down that chain of command so that we can empower each other to execute in a timely fashion. Principle 3 is during these complex events, we have to make some planning assumptions. You can imagine during all this churn and chaos, if you remember the chaos and the stories that we were hearing early from Italy around many presentations and the high rate of morbidity and mortality associated with COVID during this time frame, early in January and February, rolling into March. New York became a hotspot, Seattle became a hotspot. So we were hearing all of this information, and the challenge is, how do we focus the team? We focus the team on mission, as we just discussed. We focus the team by building our structure and organizing our team, and we needed to make some planning assumptions. And planning assumptions, again, are the idea where we want to take and make some general statements which we think are true statements, so that we can focus on the part that is variable, right? We know some things about this response. There are some things that are predictable with regard to a pandemic. We're going to see an increase in cases. We're going to see an increase in ICU volume. We're going to see some potential impacts of social distancing. So make some planning assumptions along the way so your team can take those assumptions and then focus on the unknowns. So when we focus on the unknowns with some planning assumptions across the board, then we're better able to focus our resources during a response. So here are some examples of planning assumptions from a few different entities. This is the Ontario Ministry of Health. And from the outset, and this is actually in their pandemic planning guide that was produced prior to the events of the current COVID-19. And so they take some planning assumptions in any pandemic. There's going to be a lead time. They're going to hear about events from potentially other organizations, other states, and that you'll see that they'll have some lead time involved. It will take time to develop a vaccine. It will take time to have access to antivirals. They'll be limited along with personal protective equipment. We know there's going to be supply chain shortages in personal protective equipment. So how can we plan for that? In addition to other planning assumptions, for example, that there will be a certain percentage of your staff that will be impacted, a certain percentage of your community that will be impacted. So making some assumptions, for example, 25% of our staff will be impacted or out of work, sick. So how do we plan for that type of response during the event? And we do that by outlining some planning assumptions that we can do prior to any disaster so that we make our plans based on those assumptions. Here's another example in San Diego County Office of Education. And you see, I wanted to highlight different industries and how they've approached this because, again, emergency preparedness spans various industries. So there are commonalities that we can learn from both the private sector and the government sector in how we respond and prepare in healthcare. So here are some examples of planning assumptions led by a roadmap in California by the governor there. You can see the focus here on it will be safe for schools to return to normal operations when all the following have occurred. California stay-at-home order has been lifted. The number of confirmed COVID-19 cases in the county has remained constant or declined for 28 days. The directive to physically distance has been removed and their limits on group gatherings have been lifted. And the virus that causes COVID-19 will remain in circulation until a vaccine is developed and widely used. A vaccine is not likely to be in broad use during the next 18 months, and so on, et cetera. So the idea that you can actually place in some factors that will help guide our planning and have some basic assumptions and do that across your organization are critically helpful during these events to focus your team. Principle number 4 is leading by objective. So we discussed the planning group. The planning group, again, are those individuals that think, they are your thinkers. They are the strategic planners. They take those planning assumptions that we outlined and they focus our efforts so that we can come up with some key planning assumptions. And we structured this at the beginning, thinking through on a weekly basis using our modeling. And you've seen some of that modeling from various organizations that rapidly, there were several organizations that started post modeling online to give us some projections that would give us a sense of the number of patients that we would need to care for on a medical surgical floor bed versus an intensive care unit bed. And we can make some planning assumptions based on that and then set our objectives. So at the beginning, our incident objectives were to plan for volume, and we would set them very clearly to say, next week, our incident objective by the 5th of March is to have 50 ICU beds that are COVID capable, ready and open for the potential surge of patients that might exist. And then the following week, we might say our incident objective is to have 75 beds, ICU beds, ready and open to care for COVID patients. So giving some very clear objectives, and then the operations team takes those objectives and they execute on the objectives. So they come up with a local plan to say, these are the units, these are the different areas, here's the staffing we need. And it really boils down to the S's, right? It boils down to staffing and supplies and other resources that are needed during this event, so that you have protocols and the resources to execute on these incident objectives. And the last principle I want to talk about is Colin Powell's 40-70 rule. You remember Colin Powell was a former Secretary of State for the United States. He was also the commander of the Joint Chiefs of Staff, which is a senior military member during the first Persian Gulf War in the early 90s. And Colin Powell talks about the 40-70 rule. So if you remember, again, at the beginning, as we focus our mission, we focus our incident objectives, there's a lot of data. And in many cases in medicine, data is something that is critical, obviously, that we need to rely on. But sometimes it becomes a crutch. And we become very focused or distracted by a lot of information. And we sometimes are not able to execute because we are thinking about perfection, right? The classic quote of perfection is the enemy of good. Thinking about that we have to have the 100% solution and 99% will not suffice. So when we started this, we started to acquire data and start thinking about all of these different variables that were involved, and every day information was changing. For all of us, we experienced different direction from various government, non-governmental entities, whether it was the CDC or the Assistant Secretary of Preparedness Response or FEMA, about various guidelines and directions and prescriptions for us to consider during this event. So we're really never going to be at 100% and have all of the information in front of us. So Colin Powell suggests that we use a formula, and the formula is a 40-70 rule. And P equals 40 to 70. P stands for the probability of success, and the numbers indicate the percentage of information acquired. So he essentially suggests that we really need that window of having at least 40% of information in front of us and no more than 70% to make a decision. If we're waiting to perfection over 70%, then we've probably waited too long and we're not going to execute in a timely fashion. If we have less than 40%, we're not informed with enough information, enough facts to help guide us in a good, informed, principled decision that's the best for your community, for your team when you're engaged. So really think about moving forward in emergency preparedness. We think about this construct of the 40-70 rule quite a bit during these complex crises, because they are events that are in some cases short or protracted. There's limited information. We need to make time-sensitive decisions, and we rely on the concepts of a 40-70 rule. So with that in mind, I'd like to summarize really what we spoke about here today. One is the concept of emergency preparedness and emergency management and what it does to support all of us within the healthcare community and the public safety community, and 5 key principles to consider from emergency preparedness to move us forward throughout this pandemic. Remember, we're probably on about mile 5 of a 26-mile marathon during COVID-19. So we have to keep focused and keep sharp throughout this event. As of today, there are over 30 states with rising cases throughout the United States, and we're far from complete. We're really right at the beginning. So it's critical that us as leaders within the world of healthcare can for our team, define our mission, organize our team, make clear planning assumptions to guide your team, define objectives and lead by objectives so your team is focused, and don't wait for the perfect to make a decision, and don't make a decision with minimal information. Use the Colin Powell 40-70 rule. It's been a pleasure speaking with you today, and I appreciate your time. Thank you.